JAK inhibitors have, really been the cornerstone of treatment of myelofibrosis for many years now. Ruxolitinib was approved in 2011, and then since then we've had three others approved. And they're great drugs. I mean, they absolutely bring tremendous benefits to patients in terms of how they feel, how, shrinking the spleen, improving a whole range of symptoms. But their anticlonal effect is felt to be pretty limited. We do have a survival advantage demonstrated for ruxolitinib. However, while that is there, we know that these drugs do not eradicate the malignant clone. The disease still progresses. They don't prevent transformation, for example, to acute leukemia. And you don't see the driver mutation allele burden go down substantially. So the thought is, overall, the prevailing thought is that they don't have much of an effect on the underlying natural history, underlying biology. And that is why there is a quest to find, synergistic partners for ruxolitinib or another JAK inhibitor, which could hopefully provide a rational mechanism-based synergistic combination, which then could give us deeper responses, disease modification, ultimately make patients live longer, and really have an impact on the underlying malignant clone. Selinexor is certainly among the more promising frontline combination strategies being pursued, in this case with ruxolitinib. So there was a phase 1 a trial performed in 24 patients, 14 of whom received Selinexor 60 milligram once a week, and the other 10 receiving 40 milligram once a week. And this is all in conjunction with ruxolitinib, which was dosed in standard fashion based on the platelet count, and from day one. So both drugs were started from day one. Ruxolitinib the usual way, twice a day, and Selinexor, like I said, once a week. So what we saw in this group of patients is that if you look at the 60 milligram dose cohort, which is the 14 patients who received Selinexor 60 milligram once a week, we have a really high rate of spleen response. And when I say spleen response, I'm meaning the standard SVR 35 at 24 weeks, not any lower threshold. So SVR 35 at 24 weeks was actually recorded in 79% of intention to treat patients. So this is not evaluable, which is even higher. That's something like 92. But even in the intention to treat, it is 79%. And the TSS 50, which as we know is our typical classic benchmark for symptom improvement, the TSS 50 at week 24 was 58%. So both of those, higher than really anything we've seen for frontline combinations that have been studied. But there were some other notable takeaways. So, for example, the hemoglobin, remained very stable. The drug was not, Selinexor did not appear to be myelosuppressive, which is great. Whenever you're combining something with ruxolitinib, you don't want it to be myelosuppressive. So that's always a plus. And then there was this intriguing observation that some patients whose ruxolitinib dose was very low, only 5 milligram twice a day, which is felt to be an ineffective dose of ruxolitinib, still had the spleen and symptom responses, which I think it is fair to attribute to Selinexor. And then, tolerability was another, focus, of course, particularly in the phase 1, where we saw that, nausea was certainly an issue, but that could be effectively countered with proactive usage of antiemetics. So the phase 3, for example, requires 2 antiemetics with different mechanisms of action to be used for the first 2 cycles. And that, has seemed to be a really, useful strategy. After 2 cycles, it becomes optional. In terms of analyses from the trial, of course, besides spleen symptoms and anemia, which are the three big clinical endpoints that we always assess, one would want to see things like variant allele frequency reduction of the driver mutations. That to us suggests disease modification. If we are getting the JAK2, MIPL, CALR, as the case may be, allele burdens down, then certainly, current thinking is that that is perhaps the best indicator of disease modification. And then, normally we look at cytokines, what cytokines are being modulated. We already know that ruxolitinib suppresses a whole array of cytokines, but it would be interesting to see if there are any others that this combo addresses, which maybe ruxolitinib doesn't. Or, there are things that go up with ruxolitinib, like lectin, etc. It'd be nice to see leptin, sorry. Would be nice to see what happens to things like those. And then the third one is bone marrow fibrosis. Like I was saying in the beginning, JAK inhibitors alone, at least at early time points, do not give you much of a meaningful improvement in bone marrow fibrosis grade. So that is something, one would want to see, with what we think is a synergistic combination, at 24 weeks, at 48 weeks, where are we with bone marrow fibrosis, grade changes, what percent of patients are having, reductions in that. So those are the usual correlatives that we look for in pretty much all the myelofibrosis trials, and certainly would like to see them here.